Hi everyone, and welcome to our module on the cerebral cortex. So the cerebral cortex has two halves, as you know, and each half is divided into four lobes. And the lobes are named after the bones of the skull that sit right near them. So the frontal lobe is right here in purple, the parietal lobe is here in yellow, and the space between the frontal lobe and the parietal lobe is called the central sulcus. In the back we have the occipital lobe, and then down here we have the temporal lobe, and the space between the temporal lobe and the parietal and frontal lobes is called the sylvian fissure. In the early 1900s, an anatomist named Brodmann divided up the brain into 47 different areas based on what the nerve cells looked like under the microscope. And people still refer to these today, so they'll say that a particular problem is localized to Brodmann's area 8, for example, or Brodmann's area 17. And so you should just be familiar with this. It's just a way to create a map of the human brain. So the first lobe we'll talk about is the frontal lobe, and it's the largest lobe of the brain. It does all of our motor functions. So when you want to carry out a motor action, like move your arm or walk, that's initiated in the frontal lobe. It also plans movements. And it also has portions that are responsible for things like thinking and feeling and imagining and making decisions. There are some key areas that you should know about. The first one is the motor cortex, which we'll talk about in a minute. The frontal lobe contains the frontal eye fields. It contains Broca's speech area, and it contains an area called the prefrontal cortex. So if you've ever held a human motor cortex in your hands in the anatomy lab, you know that it's composed of these ridges of brain tissue, and each ridge is called a gyrus. Multiple ridges are called gyri. Between the gyri there are spaces called sulci. One space is called a sulcus. And one of the most important sulci is called the central sulcus, and it's found right here between the frontal lobe and the parietal lobe. Just in front of that sulcus is a ridge of tissue called the precentral gyrus, and it's very important because it contains our motor cortex, which are all the cells that initiate motor activity for the body. Now, if you could pull out that precentral gyrus and turn it on its side, you would find that the neurons are lined up in a special way in terms of what they innervate in the body, and we call this the homunculus. So hanging over the edge of that precentral gyrus are the neurons that innervate the foot and the leg. After that comes those that innervate the arms and the hand, and then the ones of the face are down here. And the homunculus is highly clinically relevant when you're trying to sort out stroke syndrome. So patients who have an anterior cerebral artery stroke largely have this area affected over here because that area is supplied by the ACA. So those patients will have predominantly leg and lower limb symptoms. On the other hand, patients who have an MCA stroke have this area affected in here. The MCA supplies a very large territory, and it affects the hands and the face much more than it affects the legs. So knowing this distinction here can be very helpful clinically and on your board exams in sorting out stroke syndromes. The frontal eye fields are found in the frontal lobe, and you can tell that from the name, the frontal eye fields. They're found in Brodmann's area 8, and they have a complex function. They help us track objects and do things where our eyes need to go back and forth, like reading, for example. And the most important thing to know about the frontal eye fields is that if you get a destructive lesion of one side of the frontal lobe that involves the frontal eye fields, the eyes will deviate to the side of the lesion. So I've drawn a picture down here of a right frontal eye field lesion, and the eyes are both deviated to the right. And I talk in more detail about the frontal eye fields and other gaze disorders in the module on neurologic eye conditions. Another important portion of the frontal lobe is Broca's speech area. It's located in the left hemisphere in the frontal lobe, and it's high yield to remember that it's almost always on the left side of the brain. And Broca's speech area is responsible for speech production, not comprehension. It helps us move the muscles to speak. It helps us make speech clear and fluent. And if you ever meet someone who's got damage to Broca's speech area, they will have something called an expressive aphasia. And you should go to YouTube and watch someone with this, because once you've seen it, it's very easy to remember. These patients know what they want to say, but they can't express the speech. That's why it's called expressive. So they speak in very short sentences, they have stutters, and they have stops. Patients with damage to Broca's speech area also often have damage to the muscles of the face and the arms because of where Broca's is located near the motor cortex. So what you're going to want to watch for to identify a Broca's aphasia is a patient with broken speech that's stuttering, stopping, and starting. And here's an example of what a patient might say if you showed them this picture and asked them to describe what they see, but they have a Broca's aphasia. So they will speak like what is written down here, and you'll notice that they use very short sentences. There are lots of stops and starts. You can see they say, okay, stool, is it boy, is it that landing down? They are just having trouble getting the words out, and that's Broca's aphasia. A lot of people remember that Broca's stands for broken. Now contrast that with a Wernicke's aphasia. So Wernicke's speech area is found in the temporal lobe, I'm going to briefly move away from the frontal lobe just to keep discussing these aphasias. It's usually found in the left hemisphere. And Wernicke's area is responsible for speech comprehension, not production. So patients who have a Wernicke's aphasia have a fluent aphasia. They have no problems getting the words out, but the words are meaningless. And so what you're going to watch for is a patient who's got meaningless speech and they don't have those stutters, starts, and stops that you saw with the Broca's aphasia. So here's the same picture, and they've asked a patient with Wernicke's aphasia to describe it. And you can see that this patient says, "Mother is away here working her work to get her better, but when she's looking, the two boys looking in the other part." It doesn't make any sense. But the words are there, there's no starting, there's no stopping, there's no short sentences. So you should also look for an example of this on YouTube. And once you've seen a Wernicke's and a Broca's patient, it's very easy to recognize the two aphasia types. Just for completeness, I'll also mention that there's a global aphasia where patients have severe brain damage and lose both areas on the left side. These patients are often mute and cannot follow commands, and this can happen after a big stroke. Usually occurs with other extensive brain damage like hemiparesis and visual loss. So now we're going to go back to the frontal lobe, and the next area that we're going to talk about is the prefrontal cortex, and this is the anterior 2/3 of the frontal lobe. So remember, the beginning of the frontal lobe, right after that central sulcus, is the motor cortex, but when you go closer to the front from that, you get into the prefrontal cortex. And lesions in this area cause people to become disinhibited, they can't concentrate, they become disoriented, they have bad judgment, and they can have reemergence of their primitive reflexes. So I talk in the reflex module about babies' reflexes that they have, like the Moreau or startle reflex and some of the others. These can reemerge in patients who have damage to their prefrontal cortex. The prefrontal cortex has a lot of the things that make us human. They're things that give us our attitudes, our judgment, our concentration. So the classic description of a prefrontal cortex lesion is the story of Phineas Gage. So he was a railroad worker in 1848, and he had a railroad iron go through his skull, and he miraculously survived. But the story goes that before the injury, he was an honest and nice guy and a church-going guy, and after the injury, he became a gambler and drinker. This story's been called somewhat into question. It's not sure if it was as dramatic as it said, but regardless, the accident actually happened, and for a long time his skull was on display at Harvard's medical school. I'm not sure if it's there anymore. But this is an example of what can happen when you have damage to the prefrontal cortex. Your personality can change. Now let's talk about the parietal lobe. So one of the most important things contained in the parietal lobes is the sensory cortex. So remember I showed you that central sulcus, and on the frontal lobe side of that sulcus is the motor cortex, or the motor strip. Well, on the parietal lobe side of that central sulcus is the sensory cortex. So when patients get damage to the right parietal lobe, they get what's called spatial neglect. And this means they don't acknowledge half of their body, even though when you test their eyes, everything is okay. We call this agnosia. So they will have left agnosia. They can't perceive objects in that part of space. You can show things in that part of space and they won't see them or react to them. But if you test their vision and their somatic sensation, everything is there. It's just that their brain is not registering it. Basically a failure to respond to stimuli on the affected side. Some patients will even not believe that their left leg or arm is present because they will just think it's not there. Patients rarely get right-sided spatial neglect because there turns out there's redundant processing of the right side by the left and right brain, but this left agnosia can occur with damage to the right parietal lobe. Another important structure in the parietal lobes is Baum's loop. It's part of the visual pathway, and I describe this in more detail in the neurologic eye disorders module. But if you get damage to Baum's loop in the parietal lobe, you will get quadrantic anopia, and that is where you lose one quadrant of both visual fields. It's described as the pie in the floor, and this classically occurs with parietal lobe damage. Now let's talk about the temporal lobe. The temporal lobe contains your primary auditory cortex. This is the portion of your cortex that interprets sound. Lesions here lead to what's known as cortical deafness. It means the structures in the inner ear work normally, but you cannot perceive sound. The temporal lobe also contains Wernicke's speech area. We talked about this earlier. Lesions here lead to Wernicke's aphasia. And then finally, the temporal lobe contains the olfactory bulb, Meyer's loop, the hippocampus, and the amygdala. The hippocampus is part of the limbic system, which I talk about in another video, and we'll talk about these three parts of the temporal lobe now. So the olfactory bulb is what processes your sense of smell. If this gets destroyed, you get ipsilateral anosmia, meaning you can't smell on one side of your body. Some patients with epilepsy have a very rare form called psychomotor epilepsy, and they see sights and hear sounds and smell things that aren't there. And they can get this when they get irritation of the olfactory bulb. It's part of temporal lobe epilepsy. And you should know that the temporal lobe is commonly involved in many forms of epilepsy, It's also a common site of herpes simplex virus infection, which can lead to seizures. There are rare olfactory groove meningiomas that can affect the olfactory bulb. These are extremely uncommon, but they would cause anosmia. Meyer's loop is also found in the temporal lobe. It's part of the visual pathway, and I describe it in more detail in the neurologic eye disorders module. But a lesion here will also cause quadrantic anopia. It causes a visual field defect called the pie in the sky, and you can get this sometimes from MCA strokes and also from temporal lobe damage. The amygdala is found in the temporal lobe. It's part of the limbic system. It's a collection of nuclei, and it's important for decision making and higher functions. And when you get damage to the amygdala bilaterally, you get something called Kluver-Bucy syndrome. So these patients have hyperphagia. They want to eat all the time and they gain weight. They're what's called hyperoral, meaning they want to examine everything with their mouth. It's a very primitive form of behavior that you get when the amygdala is destroyed. They exhibit inappropriate sexual behavior. They'll sometimes mount inanimate objects. They have another form of agnosia, similar to what I described for the parietal lobe, where they don't recognize visually presented objects, and this is a very rare complication of HSV1 encephalitis. The final lobe of the cortex we'll talk about is the occipital lobe, and the most important thing to know about the occipital lobe is that it's responsible for perceiving vision. Lesions here cause cortical blindness, and it gets its blood supply from the posterior cerebral artery, and PCA strokes often cause blindness. If you have a stroke of the left or right PCA, you get a visual field defect called homonymous hemianopsia. So a left PCA stroke causes loss of the right half of the visual fields, and I talk about this in more detail in the eye modules. Conversely, a right PCA stroke causes loss of the left half of each visual field, and that's what I've drawn right here. An important caveat to that is something called macular sparing. So the macula is the central high-resolution portion of our vision. It's what we use when we read. It has a dual blood supply from the MCA and PCA. So if you get a PCA stroke, you will get homonymous hemianopsia, but it will spare the macula, and the visual fields will be drawn like this. There'll be a little circle in the middle where the vision is intact, and that's the vision coming from the macula. It gets spared because of dual blood supply. And that concludes our module on the cerebral cortex.